The last topic of the symposium is labile type 1 diabetes. We always get young people whose sugars just are roller coastering all the way, and the big debate is, are they real? Is that really a term? Is it really brittle diabetes? Is it really a labile diabetes? Or is it a result of improper treatment? Management strategies of, we will go step by step, is first we have to identify and evaluate lability. Is it really labile? Then minimize the fluctuations with dietary interventions, insulin optimization, and we have such a new variety of monitoring technology that has been talked about in these 3 days. Then address the cause of lability wherever that is possible. It may not be that easy. Psychological support is always needed because there is a root there in most of the labile cases. And finally, consider artificial pancreas and islet cell transplantation in these cases. So identifying a labile diabetes, someone with many oscillations may just be not using the right insulin at the right mode at the right time. So it's very, very important that using the modern analog insulins, the monitoring equipment, all this has actually brought down the so-called cases of labile type 1 diabetes. Now it is said to be 3 out of 1,000 insulin-dependent people are labile, and mostly it is women in the age of 20 to 30 years. It can be men, it can be older also, but mostly it is seen in young women. So to define labile today, it would be reserved for cases that are very severely unstable, whatever be the cause, and is causing disruption in their life, leading to acute hypoglycemias or ketoacidosis, or both. You can have people who are prone for only hypos, you can have people who are prone for only ketos, and also you can have a mixed picture, and this really compromises their quality of life. So a very simple evaluation initially is the duration of diabetes. When you have a patient who's totally uncontrolled, fluctuating, then the description of episodes, whether it is a description of the severe hypo or the diabetes keto episode. So it's very important to understand how it happened. Then the presence of other diabetes complications, for example, especially autonomic neuropathy, because that is going to lead to, say, gastroparesis or hypoglycemic unawareness. So it's very important to assess that. Followed by the prescribed insulin regime. That regime really needs to be examined very meticulously, what has been prescribed, how the patient has to taking it actually. Then it should be determined whether there was a period of stable diabetes. Is it that the person was detected with diabetes and has been labile all through? Or was there a very smooth period and suddenly the person started with these fluctuations, and the circumstances which led to this lability? This would give us a very good clue on where we are going. Again, psychosocial factors need to be really assessed. These are young women with type 1 diabetes in their 20s usually, and there are so many factors that influence which are probably not organic. Patients with current episodes of decay should also be seen for any hidden, cryptic kind of an infection which is underlying and has been missed. And it would be very useful in a person who is going into repeated either way emergencies to be hospitalized to observe how they manage their diabetes actually, what they report versus what is actually being done. And often we realize it is not really labile, what was thought of as labile. Once we have this evaluation ready, the next process is very standard, which we all try to do, and it is easier done today because of the available resources. So using analogs makes a big difference, using multiple injection makes a big difference. We have been talking about the pump, and these are the patients who really, really get the benefit of having an insulin pump. On top of that, if we have a sensor-augmented insulin pump, so that there is a beep when it is low, there's a cutoff, there is a high beep, so that management becomes so much better, and that whole closed-loop system would really be a boon for a person with genuine labile type 1 diabetes. Again, one part is the insulin therapy. The other part would be the monitoring part. The glucometers in such cases often are inadequate. Continuous glucose monitoring would make a wonderful difference, and flash glucose monitoring, which is available today, has really helped in reducing the episodes and predicting, because it is a real-time vision and we can predict and actually take care. Another thing which could be helping is also reducing the carbs in the diet in this case, because the fluctuation is a postprandial swing. So if just this restriction of carbs itself would minimize that swing, and that is one way we could help these people. Again, next step would be to address the actual cause. The cause could be in the mind, cause could be in the body. If it is a psychosocial cause, which is very, very common. We had a girl and finally we found the father was alcoholic, there was a lot of depression, and treatment with a psychiatrist, counseling, etc. actually made the difference, and what was actually labile was stemming from depression, and this is a very well-known common phenomena. So this is a place where good assessment and care will help. And second level is, of course, we have to go for all the other underlying possibilities, disorders, which could cause this kind of lability. There's a long list. These are just few common ones, other than stress, hormonal imbalance, poor personal care, which we were talking about, all kind of malabsorption situations, autonomic neuropathy, especially gastroparesis, celiac disease. Another girl we had ultimately turned out to be, she was in repeated hypers, and it was celiac disease, hypothyroidism, adrenal insufficiency, and so on. So all these are possible causes. There's a lot of rare causes also, but these are the common causes which we must rule out once we have done the basic evaluation and ruled out the psychological causes in these children. Psychosocial support I've been talking about, a systematic therapy goes a long way, not only in people, the root is that, but also imagine living in one moment, going into a hyper, always getting hospitalized. So even if it's an organic cause, the psychological support will be needed by a person with labile diabetes. There's a very special situation which happens, and that is hypoglycemic unawareness. We see people with a record of 20, 25, 30, 35, and they're like totally comfortable with it. And that is a very scary situation. And keeping a person at least for 6 to 12 weeks without having a hypoglycemia restores this awareness in these people. So that could be a target and can help to recover from this unawareness. Alternative approaches at the very end is an islet cell transplant, and implantable pumps would have an advantage. I think transplants are not yet available here, but that is one of the main indications for islet cell transplants, a labile type 1 with repeated ketoacidosis and hypoglycemic unawareness. So to conclude, it's very simple, but the most complicated thing to handle actually is the diabetes education, the intensive insulin therapy using analogs, monitoring as best as we can if possible with live monitoring, constant interaction, because there's a missing link somewhere, and that needs to be modified continuously. Psychotherapy is advocated. The underlying cause, if we can detect and treat, and finally, islet cell transplant. So these are some of my young girls, and when they go labile, if they are, often it is a psychosocial aspect, and we must not forget that at the end. Thank you so much.
That's awesome.